Good evening, everyone. For those of you in the UK, although I'm conscious that we have got an international audience with people registered from Australia and Singapore, it's great to welcome you to the fourth of our SAM webinars tonight. For those of you that don't know me, my name is Mike Weeble. I'm a consultant down in Bournemouth, and I'm privileged to be the treasurer of the society and pleased to be your host this evening. We've got a great programme this evening, starting off with some stuff on the acute medicine curriculum around ACPs and something that SAM have been supporting for a number of years. Some good abstract presentations, and then Matt and Inada-Kim also talking on some national COVID work. So we hope you'll all find it really interesting this evening. If I can highlight to everybody, there is a way to do question and answers, and we ask that you use the question and answer box at the bottom of your screens rather than the chat box. All of our presenters and the abstract presenters will do their best to answer the questions either in our discussion live or in responding to you on that. And we encourage you to ask lots of questions, please. Before we get going, we run a little bit of a poll just so we know a little bit more about you. So if I could have the first question, please. So as per previous weeks, quite a large amount of consultants, but it's really pleasing from my perspective, given at least one of the talks this evening, that the nurse AHP numbers are greater than in previous weeks, and I hope that reflects your interest in the ACP curriculum. Next question. So again, not surprising, a large amount of you from acute medicine, but it's great to have some colleagues from other areas, including the emergency department and out in primary care, joining us as well. And we hope you find this useful. Next question. So again, quite a lot of people with low expectation or understanding at the moment of the ACP curriculum, and hopefully that will be better towards the end. And last question before we get going. So again, a bit more understanding of national COVID pathways, but again, we'll hopefully get some useful things out of this evening. So if we just move on to the next slide, Tim, because I think you've got control. So without further ado, what I'd like to do now is introduce Ollie Phipps. Ollie is a consultant nurse in acute medicine down in East Kent. He's also been the HE-RCP ACP co-chair and has been instrumental in getting the ACP clinical framework to where we are now. So over to you, Ollie.
Thank you very much. So thank you for firstly inviting me to speak at the SAM webinar. As Mike has already said, my name is Ollie Phipps. I'm a consultant nurse in acute medicine and an academic teaching at the University at Canterbury Christchurch. And I was asked to lead the piece of work as a co-chair for Health Education England with the Royal College of Physicians. So this is a rather large piece of work, and many of you may know that advanced practice has been around for a very long time. So for the last 40 years, advanced practice has been somewhere around primary and secondary care, and it's had different guises. And with the changes in the multi-professional workforce and how we deploy staff, advanced practice has kind of come to the forefront. And this is one of many work streams. So we've got physicians associates, we've got clinical nurse specialists, and we've have nurse practitioners. But in the last 10 years, there's been significant changes. And due to reduction in the medical workforce, advanced clinical practitioners have been used to come in and help medical colleagues undertake a role that was traditionally done by a doctor. So undertaking medical procedures, lumbar punctures, chest drains, cardioversions, for example. And these people have also been on medical rotas. And as I said, these people have been present for the last 10 years. The problem that we've had is actually there's no standardization. So what's going on, for example, in Manchester compared to London, no one knows. There's no standardization. What is an acute medicine advanced clinical practitioner? But more importantly, what is an advanced clinical practitioner, full stop? So in 2017, Health Education England defined what advanced practice was. And they set about, with the help of various royal colleges, Royal College of Nursing, Royal College of Emergency Medicine, to define advanced practice. And they came up with a definition. And basically, advanced clinical practitioner is someone who is senior in their career, they're experienced, they're undertaking, and they have undertaken a master's qualification in advanced practice, or at a minimum, a postgraduate diploma in advanced practice. And they work to what we call the 4 pillars of advanced practice. So they're an expert in clinical practice. They're a clinical leader across the system. They are involved in education. So they either teach formally within university, they assist in university, or they educate in clinical environments or undertake courses, for example, as an ALS instructor or something. And also they're heavily involved in research, either as a researcher or they implement research. The thing to say is that this is defining who this individual is, and what we're talking about is a level of practice. This isn't, although in Monday to Friday, Saturday and Sunday terms, we would say actually this is a job role. This is what you do as an advanced clinical practitioner, but we need to think of it as a level of practice. Something significant happened in 2015, and that's what the Royal College of Emergency Medicine developed a curriculum based on the medical ACCS curriculum. And that was to standardize what you would expect to receive from an advanced clinical practitioner. So for example, on a Friday, I take my wife to the emergency department and they're put into acute medicine. And they're seen by, for example, a CT2 or an ST2 doctor. You kind of know the standard that you're going to get. So when I take her to hospital, say, for example, on a Sunday, and they're seen by an advanced clinical practitioner, what is the standard they receive? And the thing to say is Health Education England, with the help of NHS England, NHSI, have kind of defined what advanced clinical practice is. They came up with a multi-professional framework, and that was released, and that identified working with the 4 pillars of clinical leadership, education and research, but also what you would expect from an advanced clinical practitioner. But the thing to say is that although you have advanced clinical practitioners that work within the realms of for example, the medical workforce, you also have advanced clinical practitioners that work in other areas. So this isn't just about assisting within medicine, it's more than that. But the piece of work that I was asked to do was to work with the Royal College of Physicians. As a consultant nurse in acute medicine, I previously also was an advanced nurse practitioner regarding the deteriorating patient. But as a consultant nurse in acute medicine, I was asked to see how we could work on behalf of Health Education England with the Royal College of Physicians to develop something which was fit for purpose with an agreed team of people. And the purpose of this is about creating a standard. So it's all about understanding, if you have an advanced clinical practitioner in Manchester or in London, we know exactly what they are. For example, if you have an ST1 in, say, ACCS trainee, you know exactly kind of what you're going to get for an ST1. So this is determining a standard. Likewise, if you're a paramedic and you're on an ambulance, everyone knows what a paramedic is and what a paramedic can do. There's a set standard, and that's about defining the person's scope of practice. So we know exactly what they can do, and they're signed off to be able to do that in an appropriate way, because we need to make sure firstly this is safe and actually that our patients receive quality care. So therefore we need a standard of quality. And like I said, it's all about geographical mobility. So no matter where the person are, if they're an RCP, acute ACP, then we know exactly what they are and who they are. So in November 2018, a piece of work began scoping out actually how we can undertake this piece of work, and knowing actually there's other colleges where this is happening. So the Royal College of Emergency Medicine have undertaken a significant project which is implemented, and they have multiple people accredited or credentialed to that programme about setting the standard in emergency medicine. The Royal College of Surgeons, that piece of work is also ongoing, it's almost completed. This is also happening in mental health. It's a big piece of work that's going on, and it's all about creating standards for people. So with the help of Tom Baker, who's the Deputy Director of Education at the Royal College of Physicians, and myself, we came about setting a team of people to kind of develop a piece of work. And that included Nick Scriven, Mark Holland, Ben Chadwick and Sarah Henry, all from SAM, to ensure that this was correct for acute medicine and that we had senior doctor input. So this came inside at a time when actually another piece of work which needed the help of the Royal College of Physicians was the older adult. So with the help of the British Geriatric Society, that piece of work is coming alongside the acute medicine piece of work. So it was all about developing a curriculum, so to make sure that we have people that are fit for purpose, and more importantly, that these people have been signed off in the correct way, that they can undertake procedures and they're safe to do so, but also that we have entrustable decisions, so they're trusted to be able to do something. And if it says that within the capability framework and they've been signed off against that, then actually they're entrusted to make that decision. We needed to ensure that actually these people were able to be signed off against certain procedures. And we needed to also make sure that we made it clear that for employers, because that these people are capable of doing procedures, that's not a problem. So for example, in certain areas, there's people doing lumbar punctures, chest drains without a problem. However, there's ACPs in other parts of the country who are not allowed to do procedures because they're not a doctor. And we needed to make this clear that actually this is about a person signed off at a certain level that is capable to be able to undertake certain things. And there are many ACPs currently out there in the society at the moment who can do these things without a problem. The next thing we needed to do was to determine what common conditions would be seen. And obviously acute medicine, the common conditions list basically went out the door. It was so long, it was huge. But we've came up with a common conditions list, and all this is based on the acute medicine curriculum that already exists. We didn't want to reinvent the wheel. And more importantly, we wanted to keep it very, very similar to what already exists so that people don't get confused. And when it comes to being signed off by educational supervisors, clinical supervisors, people know exactly what happens. They're familiar with the paperwork, they're familiar with the system. So the first thing that we needed to look at were three types of capabilities. So core, generic, and specialist. And the idea with the core and generic, just like within the medical curriculum, is that actually they could flow through other curriculum. So the older adult, for example, curriculum for ACPs have the same core and generic. And if this piece of work expands into maybe cardiology, respiratory, stroke, would see the same. So for the core, these are the 6 SIPs that we developed. And this is taken in mind the multi-professional framework for advanced practice, which also includes, as well as being a clinician, you're an educator, you're a researcher, and you're a clinical systems leader. So able to function in a healthcare environment, able to deal with ethical legal issues, communication, professional judgment, professional barriers, patient safety, research, data, and developing as a learner, teacher, and supervisor. So those were the core SIPs which we developed, and this is kind of live breaking news as we speak, because this has never been shown before. This is the first public forum where this information's come up. The next thing, generic clinical SIPs. So we wanted to standardize how ACPs within the Royal College of Physicians, within medicine, work, and actually what they do. And these are the generic clinical SIPs. So we've got someone who can undertake a clinical assessment, can come up with a diagnosis, differential diagnosis, and can implement decision making and implement a treatment plan, can lead acute interventions, recognising the acutely deteriorating patient, deliver advanced life support. They're, as well as being able to work in the acute medical unit, they can also work in same-day emergency care. We also need to think that a piece of work which is going on at the moment is looking at long-term conditions. We've got more and more people coming in through our doors with multiple comorbidities. People just don't come through with hypertension anymore. They're diabetic, hypertensive, kidney disease. So it's about also having an understanding of those long-term conditions, being able to work with other specialties and special cases, being able to be part of a multi-professional team, being able to discharge effectively, and also, where previously we said resuscitation, now we're also talking about end of life. So these are really crucial skills of actually recognising when someone's end of life and deciding that actually palliation's quite an important thing. And then the acute medicine SIPs. And obviously there are a huge number of descriptors which fit under these headings. But the idea is that this is someone, an acute medicine ACP is someone who can work within the acute medical service, so either same day emergency care within the acute medical take, however the service is set up. And this is someone that would be employed to work in your unit within acute medicine, and they wouldn't rotate through. They may go, for example, have placements within critical care environments or emergency care environments, but predominantly these people would be based in one area. So therefore, they master their skills and they become an expert in that area, and they're the go-to person. And that happens with advanced clinical practitioners across the country at this present time. Thinking about delivering alternative pathways, so being able to direct people to same-day emergency care, for example, prioritising sick patients, making decisions, escalations of care, integration with special services, and the key point was to include critical care and to keep the idea of critical care. So you actually realise, so the ACP can actually realise when critical care is required and when a referral to critical care is most important, or actually when it's not appropriate. And having an understanding what critical care is about, for example, inotropic support, respiratory support, for example, and then being able to integrate and interface with the community services, including complex discharge planning. As I said, there are a huge number of descriptors which go under these titles. This is a big piece of work, and obviously I'm just showing you a few slides with some titles on, but for you to get a feel. But you'll see it's very similar to the acute medicine medical curriculum. Procedures, we need someone who can, who's versatile, can see a number of patients, can fulfill that person's episode of care maybe within the acute medical unit before they're transferred, for example, to the respiratory unit or something, or even they're discharged home. And we all came up with that this would be the most sensible form of procedures. And majority of ACPs who currently exist within England already do these procedures. And that includes level 1 ultrasound. Assessment, the Royal College of Physicians are very clear that their assessment processes work, and they work very well. So therefore, we decided that actually, why reinvent the wheel? Let's just continue doing what works well for the Royal College of Physicians and what we do within the medical curriculum. So multi-source feedback, mini-CACs, reflections, regional teaching, DOPS for procedures, and the attendance of courses. It works well. We don't need to do anything else. that's absolutely fine. Finally, we need to have governance behind it. The most important thing is that these people, when they come through their training, so they'll be undertaking a master's in advanced clinical practice and undertaking this curriculum at the same time. Or they may have already had their master's in advanced practice and they decide then that actually they want to fulfill this curriculum. Educational supervision is important, clinical supervision also important. The ARCP process, we're currently in discussions actually is this to be done at local level or regional level, and then final sign-off, and actually what would final sign-off look like. We believe this will be final sign-off by the educational supervisor and following an ARCP process and going from there. The next stage is currently work in progress. We're very, very close to finishing this. Health Education England are currently looking at a national credential against all the pieces of ACP work that are being undertaken with the Royal Colleges. So that's something that we need to consider. The other option is that actually once this person has been finally signed off and they have their last ARCP process, actually this person is awarded a certificate of completion for advanced clinical practice or similar. So these are the kind of things we're thinking of. That's kind of in the pipeline and what we're considering. As I said, it's work in progress. So the next steps for this project, we're almost there. So June and July, a proof of concept study. This is going to be involving some trainee advanced clinical practitioners and also some consultants to review it, to see if it's fit for purpose, to understand if we can implement it correctly. Once we've taken that, we've taken the feedback, we can review it. And once we've reviewed it and we're happy and we've integrated with and discussed with stakeholders, then we're thinking of a possible launch in the end of August, beginning of September. Do we have any questions?
That's great, thank you, Ollie. So we've had a few questions come in on the chat so far. I'll start with one from our past president, Nick Scriven, up in Halifax. And do you think there could be a scope for specialist interest for ACPs within this, much like the acute medical registrars do now?
Yeah, so at current times, there's ACPs at the moment. I can think of 2 ACPs that have got a specialist interest in ultrasound. Some of them teach on level 2 emergency care ultrasound, but they're ACPs in acute medicine. That would kind of happen, definitely. And there's others that have got specialist interest in for example, in respiratory as well. So I would say yes, there is scope for that.
Excellent. Then there's a couple of questions around sort of educational supervision that you've mentioned. And one of them is thinking about who do you see is qualified to act as those educational supervisors? And then also a little bit around, have you thought, as the group thought about sort of job plan time for that?
Yeah, so like how the Royal College of Emergency Medicine have implemented their curriculum, the educational supervisor in the first instance will be a consultant physician in acute medicine. It has to be. There's no one else who can fulfill that kind of role. And there is, RChem did issue guidance for that. At the moment, we haven't fully signed that kind of piece of information off. It would be recommended that this is a consultant physician being the educational supervisor, and they are given PA time for that job planning time. So, but that's work in progress.
Okay. And there's one, I presume, from a trainee ACP called Gareth, who's saying, someone halfway through their training at this moment in time, how do you envisage this being sort of implemented or affect them if it's going to come in later this year and they're partway through already?
Yeah. So I would say that the way this would work is that they would just need to undertake it. I'm a consultant nurse in acute medicine, and if I wanted to undertake this RCP accredited ACP route, then I would just need to start it from scratch, I suppose, with a understanding educational supervisors, some things may be able to be accredited for prior learning, but that would need, we haven't thought of that so far. Those kind of things will be coming out at the end of the scoping exercise.
Okay, that's great. I'll pick out a couple more questions. Somebody's pointed out from a nursing perspective around nursing appraisal within a nursing PIN aspect of things, and how you see these two aspects of things kind of reconciling.
So nursing appraisal is completely separate to the ARCP process. So an appraisal happens maybe with a senior nurse or a senior AHP, for example, if this was a physio. However, the ARCP would be an ARCP panel made up of multi-professionals, educationalists, and senior clinicians. Two different things. A lot of organisations already run them separately, so that's what would happen.
Okay, then where are we? So we've actually provoked quite a lot of bit of conversation and questions come in now, so I suspect that if you can answer some after we finish. But somebody's talked about the list of procedures and feeling that it's quite an impressive list. And do you think that that's a realistic list, particularly around, say, some of the plural work, if you're got a good respiratory department, say?
So we had long conversations, Nick Scriven, Ben Chadwick and myself, and another an ACP, lead ACP, George Stevens. We had a long conversation regarding procedures. Actually, in some units, if the majority of plural procedures happen within a plural unit, then that's fine. But normally what we're finding is there's enough patients for everyone to see them. The ACP role is quite good, that if you've got someone who can qualify as an ACP and they're in that unit, say for example same day emergency care, or they're in the procedure area or something, that they can actually help supervise trainees to be able to go to the sign-off stage. Those are kind of things that we were thinking of to consider.
Okay, and I think the last question I'll ask on here is it's come through from Rahila, that she's a clinical lead for AMPs in acute medicine and finding it quite difficult with a few consultants, particularly thinking about things like lumbar punctures or taking GP referrals, and the consultants being reluctant. And have you got any tips for her in your experience of how to break down that barrier if there's reluctance?
Absolutely. Yeah, so I think you need to network nationally and look at what is happening across other organisations. Procedures are happening all across the country, and the thing to say is that more patients are coming to the hospitals without doubt. So there's a huge stream of patients coming through, and not everyone can get a procedure on time. So actually, people need procedures, and that happens. The other thing to say is that regarding GP referrals, so the two units that I've worked in, and I think this is going to be a subject coming up shortly, the two units that I work in, nurses take the referrals, and I know there's been a huge debate going on within SAM. I've heard some really good presentations at various conferences within it. From my perspective, in the two units that I've worked in, nurses taking referrals, but also we've also had the understanding of ACPs also taking referrals sometimes. Myself as a consultant nurse, I will take referrals. The strange thing also though is that sometimes when some of the junior doctors take referrals, they'll come to me and ask me if this patient should be accepted or what we should do. So I think actually it's a multi-professional team. We all work together. People have got different experiences. I can't say any more than that, to be honest.
Okay. Thank you very much for taking time. Like I say, there's quite a few questions on the question and answer. It'd be great if you could type out some responses to those. That would be really appreciated. Thank you again, Ollie.
Thank you.
So we move on now to first of our abstract presenters from high scoring abstracts from what should have been our SAM London conference a little over a month ago now. So we'll bring in David Lanham. David is an acute medical registrar based at UCL in London and is going to present some work on 7-day services that they've done locally. Over to you, David.
Hi, everyone. First of all, thanks to Sam for having me today. This is a bit of a soapbox presentation to try and explain a service that we've been working through for the last year at UCLH, and hopefully you'll find it interesting, and some of you may want to adopt it in your hospitals. So essentially the premise is that if we start off by thinking about the point in which patients discharge from hospital, in acute services, there's often a situation where patients go home because we think that they are getting better, but when they may themselves be more nervous that although we believe their trajectory of illness is going to improve, if they go home and they become more unwell, then they may not have many options as to what to do. So the way that it currently works is that if you were to become more unwell, you can either do nothing and risk deteriorating, or people contact the GP, or they might return to the emergency department. And so what we thought at our hospital was potentially there is a role for acute medicine in safety netting these patients in the acute period after leaving the hospital. The reason being is that we may have the most up-to-date records with regards to their recent blood results, their recent investigations, and also we may have access to the doctors who saw them as they were inpatients. The other things that we have access to is we have a growing number of ambulatory clinics around the country where we can provide rapid reviews of these patients. And the other thing is that we may be able to provide reassurance to these patients because we are the ones who have that access to the information. So what we did was I set up a team of medical registrars. There were about 6 registrars to start with, and we started in June 2019, where we would provide everybody who was discharged from acute medicine with a leaflet, which essentially laid out the premise of the service to say that in scenarios where you are becoming more unwell, you can call our service for up to 7 days, and you will speak directly to a doctor between the hours of 1:30 to 5:30. And then we can decide as to whether or not we can provide advice or reassurance, whether we need to see you in an ambulatory clinic because we're concerned, or whether we're very concerned and we think that you need to return to A&E. So from that, we essentially this is the results from the first 8 months. And within the first 8 months, we received 48 calls. And from these calls, there were 3 of them we didn't have any documentation, and so it's unclear as to whether they were actual calls. And a couple of them were we missed the call and then we called back, and the GP had already sorted the follow-up for them, or they'd been seen by a district nurse, for example. But from the 42 calls, we found that 90% of these calls were deemed as appropriate. So they were for patients who are either becoming more unwell, they were confused about their medication, and we could provide advice about what they need to do with their medication, or we could provide advice and reassurance. And of the people we provided advice and reassurance only, we only had 1 person who represented for an adverse drug reaction, which was the 2nd dose of taking fosfomycin, but he was not readmitted. He was just discharged from the A&E department. And of the people we asked to come back into the hospital to be reviewed, there were 8 patients, and 3 of them were readmitted. So that the service ran quite well until the peak of COVID. And then during the peak, we were quite concerned about ensuring that we had a standard pathway that everybody followed for follow-up for COVID. And the national advice was that to dial 111. But as we started to understand that there was quite a burden on the 111 phone calls, we realized that we had discharged quite a lot of patients, and we didn't have a clear understanding of what was going on with those patients in the community. And so out of that, we developed a second project where we followed up 200 patients who were discharged with COVID. And we developed further safety net services as an outcome of that. And what we then also did was we reopened our current safety net service into a third phase a few weeks ago. Based on the previous talk, another point to make is we are now running it primarily via the ACPs as the starting point for the calls, and they're now escalating the calls when they're not sure what to do to the registrars and the consultants in acute medicine. So things that we've learned from it. We've learned that although we would imagine if we gave everybody a phone call, the opportunity to call, that it may become overused, but actually we only received about, on average, 1 to 2 calls a week. So we were able to run the service without any extra staffing. We did identify some patients who early on, who then needed readmission. And we were also able to provide reassurance to some people. There are still things we don't know about the service. And one of the things that I really wanted to look at was reattendances to the emergency department on a large scale. And we're looking to do that in the future by developing metrics by which we can analyze using electronic health records different cohorts of patients who have been safety netted, and develop a framework using safety net incorporated with our electronic health records to expand our service to all of the different specialties who would be interested to be involved throughout the trust. So hopefully this will be a continually growing field where we can bridge care between community and tertiary care. And I think that acute medicine is a very good area to be doing this. So thank you.
Excellent. Thank you, David. So we've had a few questions come in. So Miguel has asked a couple of kind of 2-point questions about how many days after discharge would you advise that patients to call you back? And a second part about if the issue could be addressed by a different pathway, say cardiology, how would you kind of manage that?
So I would say that I wouldn't say that there's any particular time that a patient should call you back, because what we want to do is, there's a lot of evidence that they initially tried to develop services where you would proactively call people, and the attrition rate wasn't great. And actually, I think if you give patients the onus to contact you when they are more unwell, then they will pick a time that is most appropriate to flag it up. And with regards to other specialties, generally, I would like a framework which incorporates all different specialties to have safety net services for their appropriate specialty, with a means by which we can liaise with other specialties that we need to, in order to essentially work less as a tribal different teams and more as a multidisciplinary service through good safety netting.
And there's one from Tim Cooksley, our Vice President, really to get a context of this, about how many patients were discharged from your acute medical unit during the study period, to get a bit of an understanding of the sort of denominator.
Yeah, so what I can say is, over a 10-week period for the denominator, we had 485 discharges, because we were looking to work out what percentage called back. And of the 485, only 3% of those patients called us. So I can't give the overall for a year, but I know it's around 3% of those who were discharged call.
Okay, that's great, thank you. There's a couple of more questions on the chat that we haven't had a chance to get to, so if you could answer those by typing, that would be great.
Okay, thank you.
And we'll move on to our second abstract presenter, so Eliza Elliott-Davies. I'm delighted to say that Eliza's joining us from the Highlands, where she's a Band 5 nurse on the acute medical unit, and is going to present some work that she and the team have done around a kind of prioritisation and screening tool. So over to you, Eliza.
Thank you very much. Hello everyone, and thank you for inviting me to speak to you today. I'm Eliza, and I'm a Band 5 staff nurse in the acute medical unit in Regmoor Hospital, which is in Inverness, and I'm going to briefly discuss the triage tool that we've been developing. I moved to the acute medical unit in October of 2018. Prior to that, I'd been working in a medical emergency assessment unit in Cardiff and was surprised that in Regmore there was no standardised method for choosing which patient was to be seen next by the clerking medic. A patient would be triaged and then all notes placed together in one box, with no discernible method for choosing who was next to be seen. It seemed to be based either on who had been waiting the longest, who had the highest news score, or sometimes which case would fit the medic's own speciality best. I felt that a system for prioritising patients was likely to increase patient safety, as well as help staff who are unfamiliar to the triaging area to feel more comfortable. Further to this, it's been a SAM recommendation since 2012. So to develop a tool for further use, there were several factors that needed to be considered. It needed to be something that was quite simple, not perceived to be adding to workload or paperwork, and requiring very little funding. Staff at the time were complaining of information overload from quality improvement initiatives, so I was quite keen not to add further to this. I then researched other systems and prioritisation tools. I had previously worked with the Manchester triage system, so I was quite inspired by this, but I needed something that required less accompanying education and guidance. The final draft I developed was a one-page flowchart, which I discussed and altered with the acute medical consultants and senior nurses so that the timeframes were accurate and the discriminators were relevant to their perception of our presenting complaints. I understand it's probably quite difficult to see in any great detail on your screens, but the idea being that this one page is within the admission packs and the appropriate code is circled by the admission nurse on triage and then paperclipped to the front of the patient notes. The notes are then placed into these extremely sophisticated and high-tech boxes you can see here, with medics starting at red and if there are no patients in the red box moving down to orange, etc. And obviously I had to give it an acronym, so it's HAST or H-A-S-T. Prior to introducing the system, we collected data as you can see on the left here. So it's just basic admission data, including the admission time, which we noted as when their first AMU News 2 score was recorded, and the time documented in their clerking booklet that they were seen by a medic. We then collected data in the same categories after 2 months of using HAST, but added whether or not HAST had been used, whether it had been fully completed, and what the code that had been given was, and whether or not this was the correct code based on the documented presentation. All patients admitted to AMU were subject to inclusion, and 12 patients were randomly selected each day over a 7-day period. Our data shows that using HAST fit much more closely to the times that it was felt to be appropriate for patients to be seen. Although we can see that those deemed to be green waited far longer in the after category, there was a significant reduction in time that those in the yellow and orange categories had to wait. We can see that although the target times are not met in any category of the after group, we are much closer to appropriately prioritising in the second data set. I also assessed to see how often the HAST tool was actually used, and then how often it was used appropriately. And as we can see here, in 86% of cases, the correct code was selected based on the documented cause of admission, news score, pain code, etc. We can see that in 6% of the cases, an inappropriately high code was selected, whereas cumulatively on 8% of occasions, an incorrectly low code was selected. The data we captured has actually been really useful and covers a really wide range of topics, so this is just a snapshot of what we got. So I have demonstrated there was better prioritising of patients when this new system was used. However, there is limited transferability to other units. As the use of a system like this has been a recommendation since 2012, most places already have a system in place. Also, there's obviously a drive to step away from paper-based notes, so this potentially has a short life expectancy in its current form. It's also worth noting that the data was collected during quite different periods. During the first phase of data collection in October, we were not finding winter pressures particularly beyond our baseline, whereas our admission numbers were quite a lot higher during March, which is when I collected data again. We also found at that time that lack of beds were the most concerning pressure as opposed to lack of staff or lack of medics. And so our medics were going down to A&E to begin the clerking process, which made the tool redundant, as obviously by the time patients reached the AMU, they had already been seen. I think another important point is that patients that are within the orange and red categories, whose condition has been escalated on admission, are not going to have a documented clerking time that's reflective of when they're actually being seen. Usually a medic would have started to see them before filling in their paperwork, obviously. Similarly, the admission time taken was based on the first documented News2 score in AMU, but after completing other triage tasks, this doesn't necessarily reflect the time the patients were placed in the appropriate box and they were deemed as ready to be seen. So I have adjusted the tool further since the one that you've seen since then. I have put a mock of what it should look like, completed with some further guidance on the back in black and white, as we had quite a few new staff rotating into the triage area and they were unfamiliar with the process and what we were hoping to achieve with HAST. There's also inevitably been a change in practice since the COVID crisis, which unfortunately has meant a change in practice away from this model at the moment. There's also a risk that it was seen as something novel that people wanted to engage with, but would become bored of and use less after. I would hope this wouldn't be the case considering the evidence base we've presented here, but it is a factor worth considering. I also collected qualitative data from the medics, and that, along with anecdotal reports from my nursing colleagues, suggested that when used, people felt a lot more confident in the situation of the triage environment, particularly at times when it was busy with multiple patients waiting to be seen, some of whom had to be transferred out of the triage area and into 5-bedded bays on the ward, so therefore not directly in front of the triage team. We have discussed with the acute consultants and senior nurses applications that this could have for future use in a similar way to the Bangor Shine trial, in that consultants may be able to see patients that are deemed as green but likely to be discharged that day and therefore streamline their care to facilitate them getting home faster. I think the tools proved to be really beneficial in this case, and it's something that I could talk about all day, so I'd be happy to answer questions now or over email if anyone wanted to discuss anything in any further detail. Thank you very much.
That's great. Thank you, Eliza. You actually answered at least one of the questions that came up during your talk about some of that transferability to ambulatory care SDEC, some of the future things. Got a question from Beth. The HAST tool looks great, but is there any mechanism to stop green patients waiting indefinitely if the take is very busy? I think that's got in mind if there's too many amber and red. Yeah,
that was actually part of the reason why, as well as it being a traffic light recommendation with the SAM guideline, that we removed the blue, which is used within the Manchester system. So there is a mechanism, I think if I can flip back to the right page, no. On the HAST, there's a space, if a patient that's green is waited for longer than 2 hours, they become a yellow. And so we have a mechanism in our triage that there's a nurse designated to check every hour to see that patients are being moved up as appropriate. So if you can see here and here, so it's the same with yellow patients, they become an orange.
Okay, that's great. And somebody else has put about, what do you think the reasons about why the target was not met? Is it just workload, or do you think there was any other
partly workload. I think we did find directly before the COVID crisis hit that our numbers were getting excessively high, which we were struggling with, but I'm glad that we did still hit the time targets, as you can see, as closely as we did. I think also, as I said, with patients that are coming in unwell, they're not going to have a documented admission time that's actually as closely reflective of the time that they were being seen. So I think, yeah, human factors are a big part of that.
And just to confirm, was it the nursing team on the unit that were filling out that proforma and deciding those kind of prioritizations? Yeah. Okay, thank you. I think you've answered most of the questions, but if there are some other questions in the chat, it would be great to answer those before you leave. So thank you for your time, Eliza.
Absolutely, thank you very much. Thank you, everyone.
That brings us time almost for our little interlude. Before we do have our 10-minute break, can I just remind everybody that midday on Friday is when applications for our current vacancies on council or our committees are up, and it would be great to have interested people applying for roles. And if you want to talk to me or any of the other members of council, do just contact us. Many of us are active on Twitter and things like that, or message me through here. But for now, we'll give us all a 10-minute comfort break, and I'll see you all at 8 o'clock. Okay, so hello and welcome back to part 2 of this webinar, and our second sort of main presentation. So I'd like to introduce a gentleman called Matt Inada-Kim. Matt is an acute physician based at Hampshire Hospitals in Winchester, not a million miles away from myself. But Matt has a role on the National COVID clinical reference group, and is also the national clinical lead for deterioration and a specialist advisor for sepsis. So has had a national role in thinking about some of this work, and he's going to present some interesting things to us now. So over to you, Matt.
Thank you very much, Mike, and very nice to meet you all. So in terms of, I guess, titles, the one I'm most proud of is that I'm an acute physician, and I have the great pleasure of working mainly at the Royal Hampshire County Hospital and working for Hampshire Hospitals, having previously been in London for my training, and having previously also been a GP. And as Mike says, I work on the national clinical reference groups across primary care, care homes, secondary care, and essentially try and pull together those pathways along those common sense aligned things that I think acute medics do particularly well. In terms of, I guess, where my head is at the moment and what my work has been about in the past 3 months, it's been about this rather simple diagram. Thinking about how we could align the management of COVID across all settings, and thinking about this hot-cold conundrum that we face in terms of our judgment at every juncture, from a patient being at home to their first encounter with the health service, either general practice or the ambulance. And then in the case of those who are particularly unwell, the triage through to an admission, usually in the form of an ED ramp triage to decide whether someone again is hot and cold, and then separate pathways thereafter. But also thinking about the patients that we send home, as we often do as acute medics. We discharge a lot of patients home, and there's safety and their relative safety netting in whatever environment they enter. So cases like this have really buoyed the need to really reflect and possibly change the way we've been managing, I guess, emergency admissions with COVID. So I don't know if you're familiar with Damien Holland's case, but he was a 56-year-old pretty well man with a touch of hypertension and asthma, written about by Robert Peston in the Spectator recently, where there were all sorts of calls for the greater recognition of silent hypoxia, i.e. the determination of low oxygen levels with a relative absence of symptoms to go with it, or indeed other compromise, which has been a real hallmark of COVID ever since day one, really. And the reflection on whether, the protect the NHS message that, has been the mantra of departmental speeches and on the podium is the right one anymore. Maybe we should be changing the message. It will take a while to change the ship around, but I think we can all cite examples where there have been quite delayed presentations, possibly harming patients. So in the case of Damien, he became sick, classical symptoms, a week after his first symptom. He became unwell and felt the need to phone 111. And there followed 2 further calls with symptoms like nightmares, hallucinations, terrible cough, joint pains. But, on recurrent questioning by well-meaning staff, he denied that he was breathless, and he claimed that he could still walk okay. Now, this remote assessment is a difficult thing to capture, particularly with the lack of evidence that sits around it. But this concept of remote assessment without even an oximeter reading becomes something that's very difficult to support based on what we have learned from the disease process so far. So the question for us really was whether to inject any degree of physical assessment into the remote or virtual assessments, and whether that might help influence and save patients such as Damien, or cases like that. So the clinical strategy has been based on 4 main pillars: aligning pathways, thinking about this remote assessment model and the virtual ward where patients sit if they're not admitted, and then the safety netting within. What that digital support might look like to actually enable this to be done at pace and scale and spread across, I guess, not only acute medical units, but also hospital ambulatory units and also the whole of general practice. And whether this actually applies to more than just COVID, whether this approach actually is the future of urgent and emergency care, and whether we should be embracing it as the future right now with open arms. And then fourthly, I guess, or finally, it was the evaluation of what these pilots would show us in terms of this approach to assessment and the virtual ward. So if you want to join in and think about potentially contributing to this national database and changing national policy as we go, do ping me an email, because it's an area we're really looking at hotly. And because of the innovators within acute medicine, I think this is the hotbed of all the good ideas. So the general principles are pretty simple. You have a patient wherever they present with symptoms of potential COVID. You do your assessment, and pivotal to that, to my mind certainly, oxygen saturation recordings. And this pathway has to work for all pathologies. It cannot just be about COVID. So the key question is, if COVID is ruled out, let's make sure we don't miss an equally serious and deadly other cause of deterioration. And then past that, the risk assessment, and then a descriptor of either putting patients into high risk and low risk categories with slightly nuanced approaches to their follow-up. I think all patients require some form of diarising together with clear safety netting, as we heard on the UCL example, which is really great. You know, let's think about who patients contact at all times of day to ensure there is 24/7 coverage for safety, and that they all get aligned safety netting and they understand what deterioration really means and what the signal for that should be. So thinking about, I guess, our first protocol was setting up the ED and MAU guidance of, you know, determining who needs to come into hospital by these sorts of criteria of using NEWS2, saturations, and the injection of this 40-step walk test or exertion oximetry to try and, I guess, get to the heart of what we were seeing on the front door, namely that people were presented either with really low oxygen saturations and an absence of symptoms, a desaturation or minimal exertion, or a high NEWS score, coupled with understanding what the risk factors are, but also being mindful of other diagnoses. And then building that in, we kind of reached out and said, what are units doing up and down the country? And the wonderful Royal Free Department came up with some incredible data recently that I have their permission to share with you today. So 1,699 patients, and they looked at NEWS2 scores on admission through the emergency department stroke AMU to ward admission and versus ICU admission. And what they found was a lovely clear delineation of higher scores, even in COVID, relate to worse outcomes potentially and worse dispositions. So it's kind of pleasing to see that it did equate quite nicely to NEWS bands, but I have to admit, we couldn't wait for this data to come through. This is unpublished, but Tara and team really need to take a bow here. And what they've also found is that saturations predict the same, kind of it's slightly independently of NEWS2 as I guess we could have seen coming, so that if you're in a discharge category, you're generally between the 95 and 100% SATs mark, which is precisely what certainly we've noted. If you come in, you're in the lower 88 to 95% mark, and ICU admission is usually below 90% at admission. Really good to see that actually physiology in NEWS2 does predict bad outcomes. And in keeping with, I guess, what we have noted, that, you know, heart rates and blood pressure is not so predictive. It does have a little bit of predictive value, but certainly not to the length of pulse oximetry and potentially the aggregate NEWS2 score. And then coupled with that, we had some good evidence from Oxford that looked at multiple studies across the world and compared symptoms. And this I found really interesting. What symptoms are most associated with severity of outcomes? And recently, we looked, what we essentially found is if you compare, I guess, severity, and if you compare severe cases that end up being intubated or that end up dying compared to those which are milder, you can do a predictive value estimation, rough and ready, of odds ratio of predicting severe outcomes based on certain symptoms. So it's not surprising that dyspnea and breathlessness out-kills or out-signals most other symptoms. The reason dyspnea and breathlessness are there and shortness of breath is simply because with so many studies involved, people use different terminology. Myalgia, chills, and severe fatigue were the other three heavy hitters and form part of every single time we should ask patients what their symptoms are. And then slower, slightly less predictive symptoms, including loss of taste and smell, diarrhea and sore throat, and nasal congestion are actually predictive of milder outcomes. We are learning more as we create the database of these symptoms. And, you know, this is why it's really important we join forces to collect that data at scale. And all of this work together to bring together the primary care guidance, which fits around those same oximetry readings and NEWS scores that we determined for secondary care. With that amber box in the middle being the crucial one. You know, if you're consider admission if you're worried, or if someone desaturates on walking, or if you just got the gut feel and concern, because actually if a normal person is desaturating down to 93 and 94, they probably do need a bit of monitoring. And then if you send people home, the question of whether some sort of remote monitoring is the right thing to do. So this works too for care homes, and we've developed it and tweaked it to add something called the soft signs of deterioration, which is, I guess, normal person speak for the symptoms of badness that a person might develop before they deteriorate. And the chart I'm most a fan of is the Restore 2 chart that uses these soft signs to track symptoms, uses News 2 recordings across care homes, and is just been recommended by the BGS and won an NHS National Parliamentary Award for this year, and is being implemented pretty much across the country. So what we will have from care and nursing home patients is hopefully ACPs and end-of-life care decision-making, escalation criteria for individualized patients, and that relate to personalized plans, News 2 scoring, and SBAR type communication. And in the homes where this has been implemented, there's been around a 25% reduction in GP call-outs, 999 and 111, as well as reduction in inappropriate hospital admissions. So it's work in progress, but it looks like it's got some promise. And then we recently did this analysis and look at rapid exercise testing, led by Trish in Oxford, comparing the data and evidence around 1 minute sit to stands versus a 40-step walk test, and came to the conclusion that roughly 3% or more reduction in exercise testing was probably the right way forward. And the recognition that a lot more needs to be done. You know, it's strange that we live in this world of acute medical assessments and ambulatory care, and yet we've never really validated the walk down the corridor test in PE and pneumonia. We all probably do it, but we haven't validated it. And boy, what an opportunity we've got. So there is an international group that's coming together to try and solve this. And again, let me know if you're interested. We have a couple of protocols that are already in draft for both the sit to stand and the 40-step walk test if you are interested. And this is an example of that, using Borg scales amongst other things. So if you are well enough to go home, where you go to is essentially this COVID virtual ward, where your entry could be the community, it could be the hospital. And at the moment, there are 2 versions of this running, the hospital version for the slightly higher risk patients, and the ones we discharge from AMU or ED potentially. And I was thinking ambulance discharges. And then you have community patients who are primarily diagnosed with a much lower admission conversion rate. So we're probably looking at maybe maximal 3 to 4% within community, and recognizing at the moment there's probably between a 10 and 20% readmission rate in the hospital ESTEC group. And then 2 groups of follow-up, either more active in the high risk patients or more passive in the low risk. And this is possibly where we determine who gets oximetry if we have a finite supply of oximeters, and then either programmed callbacks. And this has been done wonderfully in all parts of the country, of phone calls or users of apps or digital innovations, to think about how we can safety net patients in that group, together with the all-important data to come back and feed the beast and find out what we really should be looking at in patients that deteriorate with potential COVID. And TIC-19 is a great example of this, by Andrew and colleagues in the Royal Berks. Great example. Have a look on the website if you have time. It's wonderful. And Matthew Knight in Northwest London is also doing some terrific stuff, and was visited by Simon Stevens recently. So again, massive support for this hospital-based same-day emergency care kind of approach. And, you know, I'd be really interested in knowing how many acute units are doing this. There is a survey under construction. Won't be for a few days though. So the virtual ward itself works along kind of this safety netting strategy, together with a diary, to again teach people how to use the oximeter. There is a cartoon that we're producing that will teach patients about oximetry as well, and then standardized 999 111 criteria, and a diary to record baseline and new changes in symptoms or oxygen saturations. We're also doing heart rate and temperature, simply because some people have that capacity. And then we hope to really learn at scale, using a combination of computers to actually collect the data at large scale. And there are 2 groups that have already offered to study this. One of them being Aradazi's group, the other being Public Health England. So again, if you're interested, let me know. So the COVID virtual ward itself has to work 24/7. And this is where we're at in terms of thinking about what looks after patients outside of our working hours. There's no point just setting up a 9 till 9, Monday to Friday service. You've got to think about all the other times as well. And so a piece of work has begun to think about what the safety netting service should look like in relation to the community, the hospital, the ambulance service, and something called CCAS. So we will get that sorted in due course, but we haven't got that solution just yet. And then the further piece of work we're trying to look at is aligning safety netting to really bring together what we say in different areas to be the same. You know, there shouldn't be this variation. And again, with some uniformity about when to call for an ambulance and who you can wait and who cannot. This is some wonderful work that Tom Knight, who I think spoke at a previous SAMinar, and Dan Lasserson and myself did, and to look at news referrals, prediction of mortality. And, you know, this culminated in what we felt, basically, that if we asked GPs for the news score at referral, then it did predict outcomes. And lo and behold, the paper seems to prove that, both in terms of general practice, also ambulance, also ED referral. So hopefully it would give us more confidence to ask for this, because it has to come from us. It has to be pushed by the community, but we also have to ask for it and then act on the results. Because when you put it into place, as Tom showed in his really good analysis, the higher the news score, the faster we are to clock the patient. And, you know, by definition, we suspect the better patients do. And that's our next piece of work. We've got around 40,000 patients to study in this. We just don't have time to do it at the moment. But I suspect it will show that. And the question, I suppose, is whether this becomes something SAM takes on. We can let things happen to us passively, or we can take a leadership role in this. It would be good to be active in this field. And in terms of, I guess, the next steps past that, we have to consider, I guess, our referrals. So instead of just allowing referrals to happen around us, I know a lot of units are thinking about gathering that risk assessment before they arrive on the acute medicine unit. So it's amazing to hear about the Highland assessment tool, but actually, isn't the first step actually getting that data from the actual referral in a standardized way, using a standardized language of sickness, so that we can place people in the right location hours before they arrive with us, so we can get them prioritized appropriately, planned for, placed appropriately, so we can prepare as a system to give them optimal and safe care as a whole. It will never replace clinical judgment, and News 2 obviously has its limitations with conditions like COVID. We know this. I was heartened to see the RCP statement stating that it's not just about your News 2 score, but also the increasing oxygen demand that predicts mortality. And we should use our clinical judgment with that, which is absolutely the right thing to say. But as that raw free data shows, however you call it, News 2 does predict who does come in. It does predict who ends up on ICU and dying. And it does predict who goes into a hospital inpatient bed with oxygen treatment. So I think it's got a place in this as well, particularly as we need to think about the broad church of all-cause deterioration and not just about COVID. And this is just an example from where I work, and I guess what we are trying to develop in terms of that single vision of joining surgery, medicine together, and using physiology to help guide how we manage communal garden conditions within a framework that is heavily supervised by acute medicine, together with wonderful ANPs. So the opportunity is there for us and what we can grasp. And I guess, I'm sorry about the whistle-stop tour of everything that's going on in my head at the moment, but I guess what we need to think about going forward is what we use from that data to think about how we potentially remodel SDEC and what acute medicine provides, both in terms of the acute care and the assessment, but also that critical urgent follow-up of what is a very vulnerable and potentially sick group, and how we take these lessons to really remodel exactly what we do across SDEC and make us relevant and topical for the next 5 to 10 years to come, as we think about the patients at home with their acute and chronic illness and the wonderful things we can offer them from an acute medical perspective. It would be interesting to also reflect on what we need as letters to come from the centre to our acute organisations, to the leadership, to the chief execs, to support acute medicine SDEC initiatives, and the imagination within our ranks, the ideas of innovating and doing things so differently. Before people in other areas even perceive a problem, we spot it and usually try and fix it. And, you know, it's bringing that imagination to bear really at scale. And the consideration of whether this wide-scale physiological uptake of using news at referrals could be something we can study in SAMBA, whether it's something we can implement in our care pathways, and whether we will save lives as a result of this. And then other research questions along the way in terms of, I guess, SDEC and ambulatory oxygen saturations, and sharing the wonderful data we'll start to collect to think about the concept of bow ties or disease processes. And this is just an example of what COVID looks like at scale with digital information, so that we can start answering the questions that have plagued us for hundreds of years about acute medical diagnoses that we treat with consensus view and not always with the greatest evidence base. So thank you very much for all you're doing in the fight against COVID, and acute medicine is absolutely at the forefront of that, and no one says any different. Thank you for letting me speak to you tonight.
That's great. Thank you, Matt. So a couple of questions. One that's gone into the chat from David. He's talked about another seminar that he's listened to recently. It may have even been one of ours or one of the RCP ones, that actually the presenter was talking about even low news 2 patients were getting really sick, and actually that could particularly be used as a predictive tool for admission in COVID situations, and whether you've got an answer or a response to that.
I'd like to see the data, to be honest. Has it been published?
Like I say,
because I mean, I can only reflect on the 1,700 patient data I've seen from that particular study. So it would be good to not go by just what is said, but what we can see.
Okay.
Because we all have cases where someone hasn't, triggered. That's life. Yeah. A cardiac arrest from an arrhythmia is not going to show it, but it's about, I guess, proportionality, isn't it? And about not abandoning your clinical judgment.
Mm-hmm. And coming back to data, Tim, Vice President Tim Cooksley, has asked a question about the C statistic, i.e. the discriminatory value for News 2 in the COVID-19 studies. And
yeah, I haven't seen that within the data so far. I think the paper is coming, it will be coming. And I'm not sure the statistical analysis has been done in that much detail, to be honest, and apologies.
And then another question, it's just disappeared from my screen. It was about kind of COVID and non-COVID ambulatory cares and trying to run 2 separate units and things. And somebody's managed to do that, but has highlighted staffing as a challenge.
And it is really difficult. And I guess the question, if we're talking mainly virtual, which certainly where we are, we've had multiple patients through the virtual ward. Very few of them have had to come back for an assessment. We did the vast majority on the phone with an oximeter. So we bought 300 oximeters for that purpose and set up the diary. We're building an app and a computer program so that you can actually, a patient at home will be able to put their own data into a spreadsheet that we will then see real time in the hospital, and are just trying to figure out, I guess, safety netting systems within that to make it work. Okay,
excellent. Well, thank you for your time, Matt.
Pleasure.
We'll move on now to the next of our
please note what Chris Sube has said, just put in the chat box. Chris Sube has put in a wonderful 40-step protocol for exercise testing that would be incredible to study if we could. There's also that sit to stand. So again, wouldn't that be amazing if acute medicine could prove those 2 things or disprove them? Thank you.
Excellent. Thank you, Matt. So we'll move on now to the next of our abstract presenters. So we've got Martine Outador. Martine is a core medical trainee based in Oxford in the Thames Valley Deanery, and is going to talk to us about some HIV screening. So over to you, Martine.
Thank you. My name is Martine Altidore. I'm currently, like I said, I'm an ID SHO here at the John Radcliffe in Oxford. And I'll be presenting our QI project entitled Implementing Opt-out HIV Screening in an Ambulatory Emergency Care Setting. This QIP was done in conjunction with the ID team here, the HIV team, as well as AAU. It was initially spearheaded by Dr. Tom Moore and co-authored by Dr. Bunn, Mackerel, Evans, and oversight by Dr. Jones, Anderson, and Dr. Rajwani. Next slide. As an introduction, our AAU is quite unique, and it's expanded quite considerably in the last month, and we're now seeing about 1,000 patients, which forms quite a sizable chunk of our inpatient admission. In terms of prevalence, Central Oxford had a notable prevalence rate of 0.1 per 1,000, which is deemed high prevalence if you look at the definition by NICE guidelines. Over 30% of these patients are diagnosed quite late with a concurrent low CD4 count of less than 350. Next slide. We reflected back on these numbers, and we sat down and reviewed, and the question was asked, are we actually adhering to NICE standards, particularly NG60, which states, and I don't know if you can read the screen, but it states in areas of high prevalence, patients should be offered HIV testing on admission to hospital, or those who present for blood testing for any other reasons. We also had quite a few unfortunate misdiagnoses, late diagnoses of patients who presented to our AAU and then later diagnosed by our GUM colleagues, falling quite short of the above guidance. Thereby we came together and we thought how best to upscale and increase the uptake of HIV testing that patients that come via the AAU setting. And one of the ideas that came about was opt-out testing, which is recommended by NICE. Next slide. In terms of methodology, we use the PDSA methodology, the first cycle being in November 2018, which started off initially as a staff survey, which was done in order to identify both internal and external barriers to patient testing and patient counseling. And it sought to rectify that through education, through training, in order to demystify some of our preconceived concepts surrounding HIV testing and the stigma of HIV testing. That time also was useful in developing the patient information leaflet, which still is useful and used in our department today. Cycle 2 occurred in November last year, and it sought a more broader take on this work and built on the work that was done the year prior. And what we did, we came about as a team of lots of doctors who worked in HIV and ID, as well as on AAU. And we came together as champions of some sort in order to come up with ideas and interventions to improve HIV screening. And one of the means we did this was via repeating the staff survey again to see if there was any other means of improving staff understanding of HIV screening, as well as placing online and on-screen visual prompts to the service user in order to help them remind them of other differentials that should be considered in the patient that they meet that day. We also worked with IT and developed what's called a quote-unquote phlebotomy care set, which already had routine FBC using ACRP, etc., but also took out the extra thinking time almost in adding in HIV antibody antigen testing automatically so that the service user doesn't lose that memory lapse that comes with adding on another test to their phlebotomy bloods. We rolled this out on World AIDS Day, December 1st last year, and we did a week's worth of promotion, which sought to educate the staff in AAU, the acute medical staff, as well as the patients who were coming in. Next slide. If you can, the slide represents our results. On our far left, you can see the first PDSA cycle, we're quite close to that 20% line for screening. And after that first cycle, there was a bit of an increase in uptake in HIV screening, almost close to that 30% line. However, shortly afterwards, there was a significant dip, and that dip remained quite fluctuant over the first 6 months of 2019, and notably low in the summer months of last year. The second arrow indicates when we came along and introduced this champion MDT approach to the cycle in order to increase HIV testing and thereby improve early diagnosis and early treatment. And you can see a steady incline from that 30% line up to above 40%, which is quite good and quite remarkable for us, really, considering that we started quite close to that 20% screening line 2 years prior. Next slide. So in short, our interventions that we had come about in cycle 2 shows that that screening rates had improved quite considerably with a positive impact. Of course, further work needs to be done in order to continue to increase and continue consistent future change. And prior to the onset of COVID, we were hoping to have HIV screening as part of our monthly dashboard of key departmental targets alongside VTE and cognitive screening. And this is something that we're still hoping to do, but are working on it at the moment. Next slide. The slide shows some of the patient population that we get to AAU, and also how atypical some of their symptomology is. The last two, unfortunately, were missed cases that came by at AAU, but it also shows that there is quite a broad range of symptoms that HIV patients present with. The first case is a case of a 50-year-old gentleman, a 50-year-old lady who presented unwell with weight loss and lethargy, and following through the history was quite clearly deemed HIV positive. The second was a 29-year-old gentleman with bleeding gums and a normal hematology profile, and routine screening picked up a positive HIV result. The final two was one of a 35-year-old male who presented with atypical GI symptoms. He was reassured and discharged home, subsequently then presented to our GUM team and was found to be positive. The last one was a bit of an odd case, but we have a 24-year-old lady who presented with an unprovoked DVT and bilateral PEs, appropriately referred to the thrombosis clinic, and was still found to be pancytopenic despite treatment and despite intervention. And an HIV test was done and it was indeed positive. The next slide shows some of the references, and the above link is to the NICE guidance, and the below shows the Public Health England HIV stats that we used to acquire the Oxford numbers. Thank you. Any questions?
So that's great. Thank you, Martine. So you've talked about where you've progressed to so far. What do you think would be the next step and intervention that you would choose to do to try and increase that rate even further?
That's a good question. I think one of the things we were hoping to do was put it on our monthly dashboard, but maybe a staff survey again would be quite important in identifying if there's anything else the department can do to help bring about increasing HIV screening rates. Okay.
And what do you think the biggest learning for you as an individual in undertaking this project was?
I think the biggest learning point was understanding people's internal biases that they have, and some of the lack of confidence that was relayed in between the staff, who felt that they weren't aptly well versed in explaining HIV and explaining what would happen if you had a positive result. And we obviously counsel staff on the appropriate route that a positive patient would take, and we also guided them in explaining what would happen if they were equally negative. So I think understanding staff internal and external barriers was quite an eye-opening experience as well.
Okay, that's great. Thank you very much for your presentation.
Thank you.
So we'll move on to the next one now. So I'll bring in Ben Coombe. So Ben is a Foundation Year 2 doctor at Charing Cross Hospital in London, and he's going to give us an interesting case presentation. Over to you, Ben.
Thank you. So, hello there, my name is Ben Coombe. I'm one of the acute medicine SHOs at Charing Cross Hospital, and today I'll be presenting a case of new onset insulin-dependent diabetes secondary to a new type of cancer immunotherapy called pembrolizumab. So the rationale for this presentation is we'll look at a case-based presentation. We'll then look at immunotherapy as a new therapeutic paradigm in oncology. We'll look at some of the immune-related adverse events which result as a result of immunotherapy treatment. We'll look at some of the current guidance related to this new area of oncology therapy in relation to the management of these adverse events. And then I'll have some concluding remarks and acknowledgements. So today I present a case of a 46-year-old female lady who presented to the acute medical tape from her general practitioner, where she presented with a cough, blurring of vision, and osmotic symptoms of polyuria and polydipsia. She has a background of metastatic squamous cell carcinoma of an unknown primary and is currently on a trial therapy with pembrolizumab and is currently on the 10th cycle. She has had no complications with pembrolizumab so far. She has no other medical conditions. She's on no regular medications and is normally fit and well and independent and is currently still working. At the GP, she had a urine dipstick, which showed 4+ for glucose and 4+ for ketones, and her blood showed the classical triad of diabetic ketoacidosis with a profound metabolic acidosis, hyperglycemia, and ketosis. Other blood tests were unremarkable, and her X-ray and urine tests were negative. Significantly, the patient is not a known diabetic, has no family history of diabetes, and has no background of autoimmune disease. So our impression at this point was that she had a new presentation with likely diabetic ketoacidosis, with the differentials being a latent autoimmune diabetes of adults, or LADA, which is a late onset type 1 diabetes, or whether this was an immune-related adverse event secondary to pembrolizumab therapy. So the patient was treated according to a standard diabetic ketoacidosis protocol, and the diabetic ketoacidosis resolved within 48 hours. She was subsequently commenced on a basal bolus insulin regime with Levemir and Novorapid. However, we needed to get to the bottom of what was causing her new presentation, and therefore we did a new blood panel and autoimmune screen for new diabetic patients, which revealed that she had a low level of C-peptide, implying low levels of endogenous insulin secretion. She had a negative GAD and islet cell antibodies, which would normally go along with a diagnosis of LADA, but they were negative, so that would go against that. Her thyroid and cortisol tests were normal, and the amylase wasn't elevated, which would go along with a diagnosis of pancreatitis and pancreatic insufficiency. So therefore, as a diagnosis of exclusion, we said that our impression was that this was a case of new onset insulin dependent diabetes secondary to pembrolizumab. The patient is currently well and has completed treatment with pembrolizumab, however remains on a basal bolus insulin regime lifelong for her new onset diabetes. So what is pembrolizumab? So pembrolizumab forms a new type of immunotherapy, which a particular strand of immunotherapy called the immune checkpoint inhibitors. Immunotherapy isn't a new strand of treatment in cancer. It's been around for the past 2 decades. The difference is that cancer immunotherapy 2 decades ago focused on targeting particular growth factors, as is the case in Avastin and Herceptin. However, immunotherapy now focuses on the delicate interactions between cancer cells and their surrounding immune cells. One of the mechanisms by which cancer can develop is that it upregulates particular molecules that suppress immune cell activation surrounding it, particularly T cells. And these molecules are called the immune checkpoints. And 2 of the most important ones are PD-L1 and CTLA-4. Inhibiting these molecules leads to the immune system becoming activated and the generation of an immune response against the tumor. And this is how pembrolizumab works. These immune checkpoints are highly effective treatments for cancer and now have a wide range of efficacy, ranging from solid organ malignancies such as lung and melanoma towards hematological malignancies such as lymphoma, and therefore have broad applications to the acute, and understanding has broad applications to the acute medical take. So with immune checkpoint inhibitors, as with any cancer therapy, there are side effects, and these are known as immune-related adverse events. However, unlike traditional cytotoxic chemotherapy, which classically prevents with immune suppressive side effects, what immune checkpoint inhibitor patients present with are symptoms suggestive of immune activation and therefore autoimmune phenomenon. And these autoimmune phenomenon can affect any organ system in the body and can occur at any time. In this case, we present an endocrinopathy in the form of new onset type 1 diabetes. However, they can present subtly in the form of the rash, or they can sometimes lead to fatal complications such as pneumonitis and colitis. These symptoms are classically worse with CTLA-4 agents rather than PD-1 agents. And when they are used in combination, so both CTLA-4 and PD-1 agents, they are even more toxic. And these events can lead to treatment discontinuation, leading to a loss of cancer therapy for patients. So it's important that we can recognize them quickly and treat them. So guidance related to immune adverse events classically occur on an international scale, and there are very good position papers from both the American and European schools of medical and clinical oncology related to the management of these toxicities. And it relies on critical early involvement of specialist teams, including the acute oncology service, and also specialists related to the type of organ damage that's related. So in the case of our patient, endocrinologists were involved. In the case of colitis, gastroenterologists would be involved. The difference is in endocrinopathies, ongoing management is actually a lifelong complication of treatment due to the end organ damage which occurs, and therefore hormone replacement must continue lifelong. However, in other immune-related adverse events, such as colitis and pneumonitis, the disease can sometimes be self-limiting, or it can be treated with high doses of steroids with slow tapering in the community, being the mainstay of therapy. Studies related to the impact of treatment discontinuation on cancer patients are ongoing, and in relation to how these immune-related adverse events can be managed when on treatment. So in summary, immunotherapy has transformed the landscape and survivorship of cancer, in particular in the case of metastatic melanoma, which was previously a terminal diagnosis, and now we have a survivorship beyond 5 years for these patients. The complications of immunotherapy are different to cytotoxic chemotherapy and resemble symptoms of autoimmune phenomenon due to the state of immune activation that the patient is put into. From an acute medical perspective, the recognition of immunotherapy agents is critical in relation to identifying them at an early stage and recognizing their potential adverse events. When they have adverse events, there's a myriad of different presentations from acute to chronic, and they can sometimes be more subtle in their presentation rather than the extremists we present here. And in the acute management, as we have seen, the acute management of diabetic ketoacidosis is not particularly different between this patient and a standard patient on the acute medical tape. But the involvement of specialists at an early stage leads to better outcomes and can be more effective in the management of challenging cases, in particular colitis. And I'd like to thank the acute medical team, as well as Kenrick Ung and Sophia Karagiannis, for helping me construct this presentation.
That's great, Ben. Thank you very much. How do you think this has changed your practice about other patients now?
So I think the key thing related to this is about having a broad differential diagnosis for patients, and also considering that many of the medications that we give to cancer patients are not classically immunosuppressive, which is what we're taught in medical school, and we have to think about neutropenic sepsis, that they can lead to a state of immune activation and can lead to alternative presentations. Okay, that's great. That's wonderful. Thank you for your presentation. At the moment, hang on, there's a question just come in. So Tim Cooksley, our Vice President, works at the Christie in Manchester. So he's got a question of, we see 3 to 4 cases of immune-mediated DKA for our unit a year. And the important point is they're usually comorbid and need slower IV fluid replacement. I don't know whether that was relevant in your case. Not particularly in my case, but I appreciate that's probably relevant to most comorbid and multimorbid cancer patients. Lovely. Well, thank you for your presentation. No problem. Thank you so much. So we'll move on to our last presentation for this evening. So this is actually a triumvirate presenting. So we've got Rowan Gossage, who's an acute medical registrar and currently doing the Chief Registrar Programme down in Hertfordshire. And he's joined by Robert, one of the ACCS acute medicine trainees in that trust, and Jack, one of the F2s who's worked with him on a project, and they'll tell us more about it.
Hi, so I'm Rob Conley. I'm one of the CT1s in acute medicine, as I said. So we did a, this is a presentation of an audit comparing consultant and nurse-led triage phone service for the acute medical take. Authors were as below. Rowan is the registrar who brought this thing together, and me and Jack are presenting today. The next slide, please. So sort of in introduction, so the referrals to the acute medicine take previously from 2013 to 19 was a consultant-led telephone service in hours and registrar-led out of hours. There were some issues with this due to increasing demand. So the consultant carrying the phone in the morning would also be doing their post-take ward round. Obviously, when they're answering calls, this would be significantly reducing their ability to concentrate on the person, so giving poor service to the patient and to the GPs. There were consultant staffing vacancies, so the referral phone was often covered by a registrar anyway. There was a concern from GPs that this was difficult to get hold of, as obviously the consultants were doing their other clinical work, post-take ward round, as I already said. And most importantly, there was dissatisfaction with the service from the acute consultants, because they were unable to do their ward round properly whilst they were carrying the phone for the referrals. So a nurse-led phone service was introduced to replace the existing consultant service, as was based on a similar model which was already running at Luton Hospital. And this involved using 2 Band 7 nurses taking referrals from GPs and clinics. This is experienced nurses within acute medicine. Next slide, please. So the objectives of the changeover was to increase the accessibility of the referrals and free up the consultant time to allow them to focus on their own clinical work, the post-take ward round and so on. And also to make good use of the local knowledge. These were experienced Band 7 nursing staff who've been at the Trust for a significant period of time. Obviously it's been mentioned in previous presentations, the nursing staff often stay within the department, whereas the junior staff often move rapidly through the departments. And the purpose of the audit was mostly to provide reassurance to the A&E staff and GPs who may have concerns about the change in service by providing some data to show at least equivalence or if not improvement in the service, and provide us with that data as well. Next slide, please. So the method, so it was a retrospective audit, 194 days of data for the nurse-led referral service and 89 days of data from the consultant-led service. And it was collected, the data was collected for call volume per month and day and the referral outcomes. So that was accepted onto the acute medical unit or referred to the ambulatory care clinic or sent to ED or redirected to another service. There were some confounding factors. Fewer days analysed in the consultant cohort, as you can see. Significantly more Monday and Tuesdays were analysed than Thursdays and Fridays for the consultant data, but the change in the average numbers between the days was minimal when you compared it with the nursing data as well. The nursing data was surprisingly better kept, collated, and was more legible than the consultant data. There was significant numbers of consultant data with incomplete information or completely illegible. But the time frame for the data collection was also different between the nursing data and the consultant data. So the nursing data was November 18 to May 19, and the consultant data was August 19 to October 19. So there may have been some differences in that. Take over.
Thanks, Rob. In terms of results, the first thing to talk about is call volume. So no significant difference between the consultant-led service and the nurse-led service. So 27 referrals a day for consultants, 29 for nurses. Works out roughly 3.5 calls an hour. So you can see how that's quite disruptive for the consultants doing their post-take ward round. In terms of referral outcomes, once again, no big differences, but a few subtle changes to talk about. First would be that the total number of ambulatory care referrals was ever so slightly different. So nurses tend to refer to that service more often, with 37% of the calls being referred there. And the number of people being referred to ED did not significantly change, only about a 1% difference. The only other subtle change was that consultants were more likely to eject or redirect a call than nurses, but only by about 4%. So what do these results mean for us? Firstly, it highlights the volume of work that's done by that triage service and shows where those referral outcomes are going, so it's quite useful for workforce planning. It also shows that the nurses service appears about equivalent, and also that they tend to be better at collecting data, which is useful for future audits. Also, more patients being referred to the ambulatory care over AMU, and that is fitting with our trust priorities, which is useful. Also, anecdotally, we know that GP feedback is positive, finding the service easier to access and not having to wait as long to refer a patient. And most importantly, ED referrals have not increased because there was some slight concerns raised by ED staff at the beginning that there might be more patients referred to ED as opposed to AMU. And also we know that our acute medical consultants quite like it as well. In terms of further work, is there a need to expand the service in any way? So it currently runs from 8:30 to 4, but we know that more GP surgeries are operating out of hours now, so do we need to expand the service to run as like a 12-hour sort of slot? Currently at our trust, the general surgery referrals are taken by the on-call surgical team. Is there a scope for them to have come kind of nurse their triage service as well? And also importantly, this audit was performed pre-COVID-19. Obviously things have changed a lot since then, so may need to re-perform this. That's the end. Are there any questions at all?
That's great. Thank you, gentlemen. We've got a few questions come in. So Sean Harding has asked, did the nurses have a crib sheet or any training to be able to think about kind of managing or declining referrals when this was set up?
Yeah, when it was set up, it was one of the experienced nurses who'd worked in ambulatory care and acute medicine for a long time, I think a good 10 years or so. She would then interact with the medical registrars and consultants and learn on the job that way. As we're expanding the service, we're in the process of creating a crib sheet to help support, but we're mostly hiring nurses who worked in ambulatory care for many years and who know what they can take and what they can't take.
Okay, and were they standard nurses? One of the questions is, were they AMP, ACPs or
they were band 6 nurses who'd worked in ambulatory care for at least 3 years and were then taken up a band to band 7.
Okay, and did you kind of keep any data about how many times the nurses may have gone to the consultants asking advice, particularly in the earlier days, while they were still feeling more comfortable, or does that still happen now?
So no, we didn't keep detail about that. That's a very good question, and it's something we can go away and look at as we restart the service post-COVID. Yes.
Okay.
As we train up new people, I think you're right, we'll have to go away and put that in place.
Fine. And there's a thing that's come up on the chat about what if, say, the GP only wanted advice? Was there a different pathway for that, or?
So we tried to create easier access to get through to specialty advice with the other specialties creating that. It has meant it's harder to get advice for GPs, but the nurses have been going straight to the medical registrars on call and asking for them to give the advice. And that usually comes to 2 or 3 a day on average.
Okay.
But we've not kept detailed analysis of that. We find out the nurses work very closely with the acute medicine or the medical take registrars.
Fine. I'm just going back on your slides because one of the questions was about the number rejected by the consultants versus the nurses. So I just flicked back to the screen to bring that up for you.
So we found that the service changed slightly. A lot of the GPs were using it as an advice line. And so when advice was given, it was data collected as rejected because the patient then wasn't admitted to hospital. And so that's where some of the data would have come in like that.
That's great. Thank you very much, gentlemen. Thank you for your presentation. So that concludes all the talks this evening, ladies and gentlemen. Before we finish, hopefully my screen's going to move on. Tim, can you take control and move it because it doesn't want to move? So can I just remind you that next week we've got the last of our current plan of webinars with some talk about acute oncology, which is, we've had a taster from the case presentation this week. So it'd be great to see as many of you as possible back for that, and watch this space for further news after that. Before we finish, we'll just look at a few questions from a poll, and it'd be great if you could all answer those, please. So we've got a significant improvement in the ACP curriculum there, from a 15% saying high at the start to 44% now. So that's a good improvement. So hopefully that was interesting for you. And likewise, a decent improvement on the stuff around the national COVID clinical pathways presented by Matt. So again, hopefully that's been interesting for you. So it looks like most of you do like the break, so that's useful feedback, so thank you for that. And one last question. So again, that's useful feedback for us as we go forwards. All that's left for me to say, thank you for joining us. We're glad that you found it generally interesting, and don't forget to sign up for next week if you haven't already.